Welcome back to Alignment First, where we're on a mission to bring leaders back to their peace, presence, and power. And I've got the man, the myth, the legend, Dr. Michael Sumko, who has taken Humpty Dumpty, yours truly, and truly put him back together again. Dude, I'm so excited to have you in this conversation. First and foremost, obviously, because of what you did for my knee and just my overall quality of life post athletics and Marine Corps. And then also you and I have created just a tremendous friendship, man. And the introduction to your community as a result of what we've been through together, it's just been absolutely incredible and second to none, man. So I know you're busy and I really appreciate you being here today.
Hey, well, no, big thanks to you, Michael. I mean, shout out to all the veterans for your service. Thank you. That's where we first met at the VA.
Mm-hmm.
And man, I grew up a military brat, never got to serve, but was around it growing up, and just really do appreciate the dedication, that you all give the service. And so thank you. No, you're the man. I'm not the man. You're the man. So you're very kind. The introduction was very kind, but you're the man.
Well, dude, I mean, we'll get into the unicorn part of my results here in a second, but a fun fact, we talk a lot about in these conversations around serendipity and how small the world is, and you never know when you're gonna bump into folks again. And dude, we crossed paths over 20 years ago. Yeah. On the gridiron when you were at BYU and I was at the academy. We both played defense. So I don't know if we were on the field at the same time, but it was wild, because my deepest fear going into that procedure was being treated as if getting off the toilet pain-free was going to be the win for the rest of my life. And to have an athlete cut on me and to have you available through the VA. And I know that you've heard all the horror stories, just like the rest of us, about, the lack of care through the VA. Dude, I feel so blessed and so grateful that you're here on my team doing the things that you do, man. So let's start there. How does a cornerback from BYU become the guy for the VA athletes and everything else as a orthopedic surgeon?
Well, you're kind. I was exposed to it. So my father was an orthopedic surgeon, and so I grew up kind of watching him through the military. As I was a military brat, my sophomore year of high school, he got out of the military and went civilian, moved up to Brigham City, Utah. But really cool just to see him. He did a lot of home calls. It was a small town. I got to, hear back from people because he and his partner treated pretty much everyone in the town, and orthopedic wise. And so I just fell in love for an appreciation for the service he was providing. And for how grateful people were for what he did. And I was able to go on a few house calls to the ERs a couple times as we were traveling, and he had to run in for an emergency. So I saw some pretty gruesome stuff early on, but kind of fell in love really, with the kindness that the community had back towards my father and the appreciation. And all we did was talk about, medicine around the dinner table. So I never had the opportunity to learn about business or learn about something else, which actually is interested me more and more in my later years. But yeah, I was just exposed to it early on. And I thought, I really wanted to go play in the NFL. Like that was my dream and desire. And I worked really hard. And then unfortunately had an injury my senior year of college. And that kind of changed the path for me, but my backup plan was medical school, and my backup plan worked. So
dang, dude.
So I'm happy.
Yeah, was there a result? Because you tore your Achilles, right?
I tore all ligaments in my ankle. Yeah, so on the lateral aspect of my ankle, tore all of them, and then separated my tibia and my fibula. So split that apart all the way up to my knee, and so I had to have surgery where they put a screw and put everything back together.
What was it? That's awful, man. Jeez. Was there a result based on that experience and through rehab and stuff that validated or confirmed your path into medicine?
Yeah, no, I did. I appreciated the surgeon. I appreciated kind of the rehab. It took a lot longer. It would have been better for me to break both the bones in my legs and receive rods or plates and screws and tear all the ligaments. The ligaments are hard to recover and they take months. And so it was 9 months of gruesome rehab, and I was able to get back. And I went and tried to play a little bit of arena indoor football and still tried to give it one more shot at making it. And just unfortunately was never as fast or as strong again after that. But yeah, no, I think I had been pretty healthy leading up until that, and that was one of my first surgeries that I ever had. And so yeah, I started to appreciate the process of what it really takes, as you know.
Well, that was how has that experience kind of set the foundation for not only what is possible post-op, but also your expectations of your patients post-op?
Yeah. And that's a great question. I think everyone's different. I think what motivates them to get back to their full, to what their goals are. I mean, and as bad as your knee is, and I don't know if you're going to show a picture of it or not, but it was the worst knee. And I'm not just saying that because I'm on a podcast. It was the worst knee that I have ever seen, and the most amount of bone spurs and calcifications that I've ever taken out. And, I put together, I can't remember, you've seen, I think I sent you the video I put together. I kind of posted. I was just so impressed with your process, your rehab, and what you've been able to achieve, which is truly phenomenal. But I think everybody has a different goal set. So there are some people, they just, like you said, want to get off the toilet without pain. And so their expectations are here. And the most important thing I can do as a surgeon is I can help them meet their expectations.
Okay.
So when someone comes in who's a D1 athlete and has these expectations of here with a knee that starts down here, boy, I'll tell you what, you make me nervous.
Yeah, I mean, we had, you and I had some really deep conversations around expectation management. And I remember very specifically telling you, I don't want to squat 4 wheels anymore. I'm not trying to run 4-5 again. However, where's the sweet spot in the middle between getting off the toilet pain-free and like peak 22-year-old Michael performance, right? And I don't know. You'd have to tell me. Is there, like, based on the capability of the patient, is there nuance to the procedure that you do differently, or is it paint by numbers for you? A knee is a knee is a knee.
Everyone's anatomy is just a little different. I mean, my foremost, I want to try and preserve as much anatomy, muscles and tendons as possible. And everybody's range of motion is different. I mean, it starts out. And so the biggest predictor of post-op motion is pre-op motion. So if you got really bad motion to begin with, your ligaments and tendons for years have been super tight. And can I put in a knee that should get you 130 degrees of flexion? I can, but if your ligaments have only been, at 90 for the last 15 years, it's going to be hard. You're going to start to want to tear ligaments. And to be honest, Michael, I mean, I think you'd had 3 or 4 surgeries before you met me.
Yep.
And reconstructions of ACLs and horrible bone spurs. You had actually maintained a decent amount of motion, because looking at your knee, it would look like you had 0 to 30.
Well, let me ask you that. So because I was really diligent about my rehab in every scenario. And how does one accumulate all of that, all the osteocytes, bone spurs, and all that mechanical impingement that I had? Like, how's that even possible for as active as I am?
Yeah, that's a good question, because I've never seen anyone with that much bone, excess bone in their knee before. So I don't know, it's just pressures and stresses, and you over pushing it, and bone forms. The way it forms is when it's stressed, you form more bone, and that's kind of typical. Typically after an ACL, or a knee replacement, you actually get rid of the cartilage, so you're not going to be forming more bone. But you have literal nuggets in your knee. You might have to eventually, after this podcast, at least post a picture of it. You have literal nuggets, like the size of almost a golf ball in your knee, throughout your knee, multiple. And, I don't know if that was just injury, contusion, multiple injuries, continual, stress and pressure that was just applied to the knee. But that probably is what it was. And like I said, to that day, I show anybody that picture, and it beats anything out there. It really does. It really does. I'm not just saying that.
Well, then the other side of it, I didn't know how much pain I was in until I didn't have it anymore. I mean, the restored function and range of motion, all that stuff was cool, but like a straight 8 hours of solid sleep, I didn't realize, like you and I sat down and did the math. It had been over a decade since I got a straight 8, unaided, like, not after a long night of boozing or, ibuprofen induced comas. You know what I'm saying? Just like a straight 8 comfortable night's sleep. I didn't realize how much pain I was in until I didn't have it anymore. How normal is that in your world?
A lot of people experience a little bit of night pain after knee replacement for a while. But yes, the main reason we try and replace the knee is to decrease their pain, to allow them to have a little more function and to be able to do their activities of daily living. And as you know, you were able to achieve those things and much more. Which there should be a study on you, because also your video, and I don't know if you'll get into this later or not, but I mean, the fact that you can do a one-legged jump box, 30 inches off of your operative leg, that is unprecedented and unheard of. So there's nothing in the literature that says a knee replacement should get the results that you achieved. There's nothing. So everything in the literature is done on cyclic loading. It talks about how the plastic piece in between the two metal pieces wears. They recommend you don't go back to running and jumping. There's things that's based on wear stuff, but there is nothing that shows athletes returning to such a high level of performance that you have. And if you look into the pros or you look at things, you won't see guys who go back to operating at that level or playing after a total knee replacement. But you might be able to get into the next draft with what I'm doing. I don't know.
Yeah, I have a hard enough time keeping up with my 10 and 8-year-old these days. Let's not create any delusions of grandeur here. It's interesting to me because what we define as normal, right? I think that is a huge part of it. And I'm sure if I didn't know all the things that I know and have the background in health and human performance that I have, I think compared to the field, if I'm putting myself in your shoes, I'm like, this dude has no idea what he's talking about in terms of what he's trying to get back to. And at the same time, it's like, let's figure. You've already promised me that you're not going to do my revision, so. But at the same time, it's like, from where I am lifestyle wise, to it would be actually be. Correct me if I'm wrong. It would be a regression if I limited myself to the literature. Yeah.
I mean, you, as active as you are, what you do, being a health coach, a strength coach, you're an influencer in the sense that people can look at you and say, look what he's done. And for the people that are struggling just in a little bit, I mean, it really does cause you to self-reflect and go, what am I doing? How can this guy achieve these results? And I'm over here struggling with this. well, let's talk about, I mean, what is the gap between the two and what's the effort?
Mm-hmm.
What's the amount of dedication? What are the tools you have for that recovery?
Mm-hmm.
Um, it's inspiring.
Thank you.
It's very inspiring to be able to see that. And I'll let you know. So, I mean, it's funny. Just this morning, I had the morning off, and I had a doctor's appointment, and it actually got canceled. So then for myself, and so I came back, and I was just looking through stuff. My son's starting to run my social media, and
Right on.
yeah, and so Sam, he's 14, and he's starting to run the social media a little bit. I'm giving him the reins, and so he was kind of the inspiration of putting your video together.
Oh, he
And
did a good job.
yeah, and better than I can do, But he's the inspiration of doing that. And after I got it done, I sent it out. I was so appreciative. I know you did the majority of your therapy on your own, your rehab. You've continued to do it. You haven't stopped, and that's why your gains just continue to go up. And a lot of times in the community, we don't see the end results as such as that you have, but because we're friends, and because I follow you, I get to see the stuff that makes my stomach drop sometimes. But it's truly inspiring and amazing in a sense that you can actually do that. And so I actually sent out the video my son had made, out to all of my therapists, every single one of them this morning, just telling them how grateful I was. I can do so much, but what happens after surgery is the key. And I wanted them to send them your video to show them, thank you for rehabbing and working with these patients in therapy. Disclaimer, I don't say that you do box jumps with all your patients, but most of us can't do one leg box jumps without a knee replacement. But
right.
I said, I appreciate that there is an aspect to rehab and accountability and hard work and leading people, as therapists into having the most successful outcomes. And so I sent that out to a bunch of them, and yeah, you should have seen all the exclamation points that, and wows and unbelievable and beast hashtag, all these things. But I mean, it's something that they hadn't seen, and honestly, I hadn't seen either. So I think there's a level of dedication. There's a level of some people set goals and not get frustrated, and you have an amazing capability, I think. And and I told him, I was like, this guy's D1, and I think to be D1 in college, there's something that there's a drive that goes beyond what's normal, and you have to, and you've had that throughout and you have abnormal results. So,
well, to that end, how did you? Because I know you have guys that you played with, just like I do, who their career ends before they want it to. And I know you say that medicine was your backup plan, very tongue in cheek, but how did you I call it the death of identity, especially when you don't go out on your own terms, right? How did you not get lost in that cycle? Because you even tried to keep it going.
Yeah.
Right. How did you keep yourself from getting stuck?
Yeah, it's hard. That's the hardest thing. I tell my son that all the time, and other guys I know who are playing sports who have the ability to go play college and potentially professional is, in football specifically, no one walks off the field when they want to walk off, unless you're Tom Brady and you're protected. But unless you are the man and you have all the protection. But football never ends on your own terms, and that's one of the hardest things. And I think that's why you have a bunch of those has-beens that want to be and continue to be around the game because they felt like they could have done a little bit more, and that's hard in life when you get stuck, like you said. For me, I after my injury, because I had an ability to go to the combine, and once I got injured, I was kind of taken off that list because I had tested well and I ran the 4.31, and next thing you know, all of a sudden there was opportunity.
That's so fast. For the record, I just have to say this out loud because if you're not a football fan, I don't think you have an appreciation for how fast a 4.3 is. Okay. The only reason I put down 4.52 is because I was running next to a guy that ran a 4.3. Okay. That's incredibly fast.
No, yeah. I was blessed. I made goals. I worked hard for it, and was able to test well for the scouts my junior year. And basically, I think had opportunity to go, and I would have done well at the combine. I'd set my goals. And
could you have declared early? Could you have
my junior year
entered the draft your junior year?
I guess I hadn't thought about that. I was a walk-on, and so I had started as a nickelback and did all the special teams. And so my senior year, I mean, I think I wanted to be there. I wanted to be have a starting position and play. And I loved all my teammates. And so I think it wasn't something. It was the summer after my junior year. So right before going into my senior year, I ran that 4.31, and that kind of just set things up for me to all of a sudden I started getting all these letters, in my mailbox, and it was like, what have you done, Sumko? You're a walk-on, you played nickelback, and you had nickel in, and you did the special teams, but it's because I tested so well for our pro day at college, and it's unfortunate that I tore all the ligaments, and that was the end of my season, early on, but regardless, yes, when you get stuck, I could not watch a football game for about 2 years afterwards.
No shit.
Yeah, I couldn't go to the stadium. I went to one game and I sat in the stands, and I heard people just kind of making fun or yelling at some of my old teammates down there, and it pissed me off. I turned to them, I said, "You don't know how hard that kid works. Like, you can't." They didn't know who I was, sitting up, but I said, "You don't know how hard that kid works." I got up and left, and I couldn't. It was hard. I couldn't even watch a game because I wanted to be there. And and I met my wife, and at that time I thought, you know what, I have to get serious about what I'm doing. If I'm going to get serious and marry this wonderful woman, and so I kind of had to bury it for a few years, and it was hard. And I stayed away from the program. I stayed, went out to med school back east, and just kind of got locked into med school and busy, and didn't start getting back involved into the program several years later until med school residency. Busy 9 years of my life, but during my fellowship, when we moved back west, started to be more involved in the program again. But it was hard, and I had a son, fortunately, that was able to play, and I kind of live a little bit through him and get to see some things, but try to stay back a little bit. It's tough.
I mean, your wife's an athlete. You're an athlete. My wife's an athlete. Give me the wisdom, man, because you've got 3 kids.
Yeah, 4 kids now.
4.
Yeah, 4. My oldest married out of the house, and then my 3. Yeah,
that's right.
2 boys, 2 girls. Yet
I haven't met your oldest. That's right. Okay, so how do you go about supporting? From what I can tell, very what's the word? Ambitious, high achieving children, and at the same time, like doing it in their desired pursuits as opposed to imposing what dude, you had a shot at the league and you're a surgeon. Like, how do you not? What's the work that Mike, not doctor, that Mike does on Mike, so that you're able to just support them as opposed to impose your will and your standard for achievement on them?
Yeah, that's a good question. And I wouldn't say I'm perfect at that, or even have learned it. I think that's part of parenting. Many times, I've had a lot of lessons, and I'm sure there's been a lot of things I could have done better. I think my son is a phenomenal athlete, 3-sport athlete. And he, just growing up and going to games and stuff. I mean, I wanted to talk about teaching him, like, hey, this is what you can do better. He didn't want to know that after the game, and I've learned multiple times, he'd be frustrated, and I would want to say, well, if you actually play defense like this, you're not going to get beat. like this is where this is how you're frustrated because you got beat on this play. This is how you're not going to get beat. And I'd want to teach him, but you know what? It wasn't a moment for him to want to be taught. And so I think he just wanted to be validated that, and so that is hard. I think as parents, you got to let your kids fail, right? You got to fail to succeed.
Yeah.
And you got to just be with them there and hopefully develop a relationship so that when they are ready to learn, they come to you. And I think that's the hardest thing. For the longest time, my son playing receiver, I played receiver in junior college and then DB at BYU. So I played both sides of the ball, and Mikey's a really great receiver. And I'd sit there and I go, Mikey, let me come out and let me jam you up. Let me teach you the defensive side of the ball so that you know what's happening on the offensive side of the ball. And he's like, Dad, I already know what's happening on the defense side of the ball. Like I work with a coach.
Sure.
And I just wanted to go out there and I was like, I can teach you how to be fast. And he never had a speed coach or anybody. And I was like, Mikey, let me teach you, and even remember I tried to get him to work with you. I was like, Mikey, come work with Michael. And, he's just, I don't know. I think for him, he wanted to cut his own path and be his own guy. And he didn't want to hear, oh, you're Mike's son. Or,
so how is that for you as a father to support and embrace your kids' independence? Because I think that's a feather in your cap, and I'll let you know when I cross that bridge myself. But I mean, you kind of want that in your kids, right?
Yeah.
Is it counterintuitive that you want that and it like stings too?
Yeah, it hurts. Yeah. I don't know. I mean, a lot of times our kids just want dad. They don't want coach. And my senior year, I did help out with the high school my son's senior year, my son's sophomore and junior year, I did help out with the high school on the football team. And then it came to senior year, we got a brand new coach and I told him, hey, I'm going to step away. This is a senior year. I want to be a dad in the stands. And, and that came from my wife really pushing me, to say, hey, this year, let's not have you on the field. Let's let him, and, and it was hard to watch from the stands, but it was great. And
I was in the stands with you a couple of those games. So I know.
Yeah. So it was great. I obviously love being down on the field too, but I think in our lives, I think it's a win in parenting when we can decide, is it time to be the coach? Is it time to be the parent? And that's hard. But if you can figure out when those moments are, when you can, and they don't want to lecture, they don't want you to impart your knowledge. And it's tough because I feel like, man, I had all these years of experience at wide receiver and defensive back. Like, let me talk to you about this little move and let me, but if he's not in a moment of being taught, and I think, what happens is you've got to connect. I think connection is the most important thing. So before you correct, you need to connect. I heard that once.
I love that.
And if you don't connect before you correct, they're not going to be ready for any insight. So you got to connect before you correct. I heard that at a relationships class once. And
dude, I love that. And I can only assume, just based on my experience of you, patient and doc, that transcends your relationship with your family, and that's integrated in your practice as well. Yeah.
I'm preparing to give a lecture, an orthopedic lecture on building a practice.
Okay.
That's one of the things for all the new fellows coming out and residents coming out. How do you build a practice in a competitive market? And one of the things I was reading up as I was studying is trust is currency.
Yes.
And so building that relationship of trust, and no matter what you do, I mean, I see 40 people a day. I literally have, 10, 15 minutes in a room. How do you build trust with the patient?
Right.
And it's not something I focus on or I try and do, but when I look back, there's things you can do real easily that are just natural to build trust. just trying to, and you know me, I don't come in with my white coat on and shirt and tie. I'm mainly in scrubs. I don't want to ever be that intimidation, I didn't
Well,
want to.
dude, I got to tell you, man, I don't know if you know this or not. I almost backed out on our procedure.
Because I was too casual.
No, man. I remember because, dude, I'm working my way away from this pattern of stuffing 10 pounds of shit in a 5-pound bag, and my procedure was later in the morning, and I ran a staff meeting at the gym before Nicole brought me into the hospital. And it was not because I needed to get this message to the team or stabilize the boat. It's like, I need to put as many things in front of this thing to distract me from what it is.
Yeah.
And dude, she'll tell you the story too. Dude, I cried. Like, I was just sobbing on the way to the hospital, man, because I have quite a bit of white coat syndrome.
Yeah.
My old man, and I know exactly where it comes from. I've done so much of this work on me. My old man had a heart attack when I was 16.
Oh, wow.
And he was in the hospital, and I wouldn't go see him because I didn't want him to code in front of me. That was my deepest fear. And I created a narrative around that experience that the hospital is where people go to die. Right. And it was like so overwhelming. It crippled me that I was going to go in. We were going to do this thing. The lights were going to go out and I wasn't going to come back. Just a superficial, unrealistic, irrational fear. But dude, it was wild. And then, getting to, all the bright lights and white rooms and the epidural, dude, I was like, I don't know if I can go through with this. And you and your team were, not like, well, dude, it's not too late to back out. You didn't acquiesce like that. And at the same time, it was like, dude, we're going to take care of you. You're going to be okay. And it calmed me down enough, but I was 60-40 on whether or not I was going to make Nicole just turn it around and say, nope, not going to do it. We're just going to deal with this shit,
We're out.
Yeah. So do you know that that's your patient? I mean, I had some very obvious, there will be signs, right? But I mean, are you aware that these are the things that go on in your patient's minds leading up to a procedure?
Yeah, I think, a lot of times I can tell some that are more nervous than others. Some that have got to the end of the rope and there is no other option. So they know that, and I think when you get to that point, they have a little more peace. But I mean, I'm afraid to have surgery. I had a colonoscopy and I was like, oh gosh, please don't perf my bowel. Please don't, please don't do this.
You know too much.
I know too much. And so when I opened my eyes back up, I was like, oh, thank you. And it was just a colonoscopy. I wasn't getting my knee replaced or hip replaced or, any major surgery where you have cutting bones and have potential of some really bad things. But yeah, no, for sure. It's, there definitely has to be a trust and a confidence and, and that's why I love the social media aspect of it. I love posting videos. I love people seeing like what can truly be the results. And I think that's better than sitting across from a stranger you haven't met, some doctor you haven't met, and him telling you, I'm going to do this, you're going to be all right. And so, so yeah, I think there's, in community, and finding the people who've been through it, having that support, because everybody knows someone who's had a bad knee replacement, bad hip replacement, or an infection, or died, or amputation, whatever.
Right.
But finding, surround yourself, obviously first for me, surround myself with a team that makes me better. That helps me to operate at my highest potential.
Mm-hmm.
And that's what I do. And then constantly just having that desire for me never to accept where I'm at, to always be better. If I'm not better than I was last week, then, what am I doing? And so that's what I've kind of designed my practice and really my focus. Treating patients is like, you should be better and better. The more you do, the better you should get. And if not, you're leaving something on the table. And so, it's I think it's a combination of a lot of things, I think, to try and gain trust in patients, but trying to connect. And I think everyone's a little different. Everyone has different goals and expectations. And where I feel the most uncomfortable, and this is probably be interesting for you.
Yeah.
I feel the most uncomfortable operating on someone is when they have an expectation that I'm not sure I can meet.
Oh.
Well,
let's talk about it, man.
I actually get a little pissed. I don't want to have that stress going on in the surgery.
I'm your best patient and your worst nightmare at the same time.
Yes. No, but when you had your surgery, though, at your time, I would have never expected you to be doing single leg box jumps with your replaced knee. And I don't think you expected it either. That was not your expectation. Like you said, you just said, can you get rid of my pain? Can you make it so that I can get a little more motion in my knee so I can, raise my kids?
Yeah, 100%.
And
mission accomplished, man. And
so that was easy. You, dude. Yeah. And I looked at your knee and I was like, this is the worst thing I've ever seen. It's almost impossible for me not to make this a little better. So I felt good with you. Surprisingly.
Good news. You can only go up from here.
Yeah, I don't know if I can make this much worse, honestly.
Well, dude, when we met, I don't know if you remember this. Our first initial counseling was, I remember my X-rays were up on the thing, and you walked in, you looked at that. And then you looked at me and you were like, I'll be right back. And I think you went and tried to go get some, you thought the wrong X-rays were up there.
Yeah. Oh yeah. Oh yeah, I did.
I don't pass the eye test.
No, I walked in and I was like, this person's going to be in a wheelchair. Where's your wheelchair? You didn't have a wheelchair in the room. So I was like, wait a second, this is the wrong X-rays. And you're too young to have a knee that looks like this. Like that was, And I wish I had the X-ray. I could pull it up on my phone and like put it.
Oh, dude, I'm gonna do something sexy in the show notes for this one, because I don't think people understand, because when I show them the picture, and I wish I was tech savvy enough, or I had another person in studio with me that could like put this thing up on the screen or whatever. But the way you explained it to me, like the stuff on the tray, he's like, this is what's supposed to be removed. And then you had the tin. And you're like, this is everything else. And it was full. You can't see the bottom of the tin.
No, it was more than it. No, to this day, when I show people, the surgeons themselves don't believe it.
Well, what I was going to say, what do your peers say about, like, if you didn't know me and you were the only thing you had were those images, what would be a realistic outcome of that procedure?
Man, to hope that you can walk and have more than 45 degrees of bend.
Holy shit.
Yeah, wow. Honestly, and just be like, can you walk afterwards? And so honestly, I'm presenting you, and I was going to ask for your permission, obviously, to do it, but to present you at this conference. I'm up in Salt Lake presenting at conference, outpatient total knees and subvascus not cutting the muscle, and the results. And obviously, I'm going to show my best result, which will be you. Most incredible outcome, and I have a lot of great outcomes, but I mean, not to the degree of post-op strength and ability and function that you've had. But it's still great. I still have great people. Back to what I was saying, because I do want to tell you this. So just so you know, when I'm uncomfortable, and I don't like to be uncomfortable. So I was this happened this last week. This guy comes in. He's a younger guy, big swollen knee, really bad arthritis. He has barely any bend. I mean, it's not a functional leg. It hasn't been functional for years. He's putting it off because he's afraid.
Mm-hmm.
His knee's like twice the size of his other knee, and he
I'm
looks.
I'm going to pause you really quick because I think this is also really important. I'm 42.
Oh,
I
yeah.
had the surgery at 40.
Yep.
Most people have this procedure done when?
There's a big range. 26
Okay.
is my youngest. That's kind of that's out there. Not your most people are in their 50s to 65, 70.
Okay.
Yeah.
So when you say
So
this guy's
you're
a
having it.
younger,
Yeah, you had it about 10 years earlier, but I do replace a lot of athletes who have been,
mm-hmm.
been through it and have had multiple injuries. So yeah, that is true. You are younger, but
Yeah.
regardless, still it's an incredible
So,
recovery.
so when you say this guy you're about to talk about,
Yeah.
when you say he's younger,
He's younger. So
where is he on that spectrum?
He's like 48. He was 48.
Okay. Yep.
So he's 48-year-old guy, and and we're getting ready to roll back, and he's like, I got one more question for you. One more question for you, Doc. He's like, yeah. I was like, what's that? And he goes, you're going to make my knee smaller, right? Like the swelling's going to be a lot less. Like it's going to be smaller. And I looked at him and was like, how long has your knee been that big and swollen? He's like, 10 years. And I said, I probably won't. I'm going to do the best I can. And I hope it doesn't swell afterwards. And I hope we can, make it smaller. And then I got back there and he had the worst motion and just a very, very difficult case, and I'm sitting there going, how am I going to give him the best result, with very, very hard knee, probably in my top 10 hardest knees. And
wow.
he's worried about it being just a little skinny.
Right. So let me ask you this: how often are you, because you obviously have a working knowledge of what the imaging presents. How often, percentage wise, do you get in there and you're like, holy shit, they don't line that, it's different. It's a different scenario than I was planning for.
Yeah, that's probably good. I would say probably 1 in 50 knees or whatever. Okay. You get in there and all of a sudden, once you open it up, you're realizing that their ligaments aren't intact or it's functioning different mechanically. The mechanical function is off. And so when you try and match things up and you kind of stick to what you're doing, functional wise, you got to make it all match. And so it becomes a puzzle that you're trying to work backwards. But it's good.
From a symmetry standpoint, are you ever like playing with the good leg to judge what you can get out of the operating?
Yeah. So every now and then, like someone, once we put it in and we do it, they might have real loosey-goosey ligaments. And I'll say, hey, let's check our other leg. Does that hyperextend too? And, if it hyperextends, I don't want to just get you stuck it straight, because if I don't give you so that you can hyperextend a little bit, you're not going to match your other side. You're not going to be happy with it. Right. And I definitely don't want to put it in tighter. So every now and then, we do have to compare sides when it's kind of a funky knee. But I always tell people once they're asleep on the table and they're not guarding or anything, I always take them through a range of motion, test it and go, okay, this is what I'm expecting. And sometimes I'm like, holy crap. Like in the office, it didn't feel like this because they were guarding. They didn't want me to move that knee. They were guarding, but now they're asleep and all of a sudden it's just like, whoop, but I have everything in there to do it. So every now and then, it is a little bit more work than I expected, but I'm going to do the right thing and take as much time on everybody.
Yeah. So here's my next question, because you had made mention before we went live that you've been doing what you do the way that you do it for 11 years.
Yeah.
And the market, the public awareness of the way that you do it is only like 5 years old.
Yeah. Yep.
So how do you go about, this isn't a marketing question, but it's like, if you're so far ahead of your time with regards to muscle sparing, is that the correct terminology?
Quad sparing. Yep.
To me, as a strength and conditioning coach for 20 plus years, that just seems logical. You'd want to spare as much soft tissue going into these things as possible if you could. And as I'm hearing you tell it, the message is like, that's not true. This is a new normal. So what did it used to look like compared to what
Yeah.
you've been doing for over a decade that is now
Yeah.
just catching fire?
Yeah, that's a great question. So it's called a medial parapatellar approach, meaning that they go up on your inside of your tendon, patella tendon, around your kneecap and into your quad muscle, and they split the quad muscle. And that's the normal way to get in. So your quad is four. It's the four muscles that come down your thigh. They split the tendon right up in it. That's the normal way because that's what opens up the knee enough to give you access to do the surgery.
Okay.
Less invasive or muscle sparing or quad sparing or subvastus, which is the way I do it. You go up along the medial part of the tendon, you get up kind of by the kneecap, and you go right underneath where the quad starts on the medial side. So then you pull the whole quadriceps over and you never touch it. And why don't more guys do it that way? It does take some time and some special training and technique, and you really got to buy into it, and there's a learning curve, and you got to be really good about figuring things out. If you can't get it, if there isn't mobility in the quad, where do I do my next release? And there's a learning curve to it for sure, and I just kind of bought into it because when I started doing it 11 years ago, the therapists started coming to me and saying, what are you doing? This person walked in post-op day 5, no walker, into physical therapy. And I saw him and he said, I'm here for a total knee. And I told him, no, you're here for a knee scope. He's like, no, I'm here for a total knee. And he goes, are you sure you had a total knee? He's like, yes, I had a total knee. And that was my first therapist that came in. He's just like, I couldn't believe it. And then more and more therapists started to want to come follow and watch me. So I started to realize this is different. And this makes sense. And my fellowship director always taught me, if you can protect the tendons, the ligaments, keep anatomy as natural as possible, people are going to have a better result. And so it's true. But yes, to answer your question, in a marketing where there's some big marketing machines in the market that have come out and started to, train people in not cutting the muscle. And it is a huge marketing machine, backed by lots of money. Luckily, unfortunately, I've been able to, I think, hold my own because of the results. Because I am developed in the community. And I do, you look at building relationships of trust with therapists, with marketing. I think the best thing you can do is, I looked at my thing. I probably have 80 physical therapists in my phone. And that's just because I said, hey, you got a problem with one of my patients or anyone's patients, and you just can't get a hold of the doctor and you just want a second opinion, or you want to shoot me, let me know. And so I think being able to have that trust that, hey, I can pick it up, approachable in any marketing, not just in surgery, but in any marketing. Hey, I'm available, I'm affable, and I have ability, the 3 A's.
Yeah. Well, because when you get into any of the soft tissue, muscle, tendons, ligaments, that prolongs recovery.
Yeah.
Right.
Yeah. Yeah.
As opposed to just dealing with the structure as I had done, and the site, the incision site. That's really the only healing that needs to be done. Correct.
Yeah.
That's kind of that's the difference.
Correct. Yeah. The capsule of your joint. We have to get into the capsule. So it's just the capsule, but it's not a tendon. It's not a ligament. It's not a muscle. And then, your superficial skin. Yeah. So it's a lot. Your quad strength is still strong. And and so it's wonderful. It puts you 6 weeks ahead in therapy from day one. And that's how I'm able to do 100% outpatient. I send everybody home same day. 94 is my oldest, 26 is my youngest.
Wow.
And so the streamline. And my 94-year-old guy lived alone by himself. Like he was.
No shit.
Yeah, he had his neighbor drive him, and he kind of meal prepped, and we kind of optimized him and talked about things to do. And he was a healthy 94-year-old. My fellowship director always said, "Don't treat a birth certificate, treat a patient," because there's 90-year-olds that are healthier than 60-year-olds. It's true, and so I think that was that's another thing I think in life, right? You got to look, you got to look inside the person and not just skin deep,
Yeah.
I think when you start to, try and understand people for whatever aspect of connection you're trying to connect with them. That's what makes a big difference.
Now, I know you're not an anesthesiologist, but let's go post-op and talk pain management.
I'm an orthopedic surgeon, though I could have been an anesthesiologist. That was my backup plan.
I can't cut you open. I can't stitch you for shit, but I can put you to sleep. Okay. Where are you at with regards to speaking of the VA specifically? Veterans, the opioid crisis, 22 of us losing, taking ourselves out of here a day. I think that's still the stat. How do you, when you have your patients out of the VA, how does that conversation go when you're prepping them for life post-op? Because like for me, I feel very fortunate that I've got a very negative and visceral reaction to any and all things hydrocodone, Vicodin, Percocet, all of it. Like I get really backed up, really awful constipation, and like my insides just hurt. That the pain of the surgery is easier to deal with than the gut pain I get from trying to stay out of pain.
Yeah, no, it's a good question. So I have actually would not cut in. So I look at the whole procedure from before surgery. So when I have a successful knee replacement, and I've kind of developed this over the last 11 years, is I call it the 3 phases to success. What we do before surgery, the blood work, the nutrition, the optimization, the weight loss, the control of your sugars, the stopping smoking, stopping drinking, all these things going before surgery. I try and check the boxes, stop the medications and vitamins and supplements that are going to cause you to bleed more. Then I go into surgery and I go, the anesthesia, short acting spinal, so that you don't wake up groggy. It's like a colonoscopy. We give you a propofol drip. I do an adductor canal block. We block locally. We do all this stuff. I don't cut the muscle. We optimize you in surgery, and that's on me and my team. What happens in the recovery? Icing, ice machine, icing, elevation, doing calming down the knee, doing gentle motion the first couple of weeks, and then starting to really get into it. Basically looking at these 3 phases and what everybody does. With medications, I don't give narcotics anymore, and so I've been doing that now for about a year. So I was always giving that.
That's your call.
That's my call. So
Holy shit! Really?
Yeah. So anesthesia will give you a little stuff like a propofol drip to keep you under.
Right.
And they may give you a little fentanyl or something in your IV if your heart rate starts to spike or something during surgery.
Okay.
But after surgery, you get 1,000 milligrams of Tylenol every 6 hours. You get a baby aspirin twice a day. You get an anti-inflammatory once a day. And then you get an antibiotic. And those are your scheduled medications. The 2 as needed are a muscle relaxer if you need it, if you're getting spasms, but it's more to kind of help you become a little drowsy if you have a hard time sleeping, which is true. And then I used to give 5 milligrams of oxycodone, just a small dose of oxycodone for breakthrough pain. And I was finding people were only taking 1 or 2. Yeah. And then once I started making sure that everybody had an ice machine and they were icing, compressing, elevating, that was actually doing better for their body and their soft tissue in their knee than the narcotic. So then when I started to find out people weren't even taking that 1 to 2, I said, that's it, I'm done. So now I prescribe tramadol, which is an opioid synthetic, does not make you constipated. And once again, a lot of my patients will only take 1 to 2, but it's there if they need breakthrough pain between their Tylenol. But I'm getting to the point where about 85% of people are just using the ice machine, the Tylenol, and not using the tramadol. So there is another medication called Journavx, which just came out, and it's kind of a time release, blocks your pain receptors, and that's also, it's a non-narcotic, and that's also starting to show some good results. I haven't started utilizing that yet, but I may look into doing that as well. But yeah, it's getting better and better. I think it's a mindset, and I think it's some education and it's some compliancy. You can bring everybody together with that, optimize the patient, give them the right amount of education, give them a tool set to be compliant, and the ability to control their pain afterwards. You can keep them off. So yeah, opioid-free total knee.
Dude, I had my PT was badass post-op. Shout out to Kathy Monda at 360 PT. She was really good, and I gave her permission. I understand, like, from a mindset and personal expectation perspective, I'm different from the field. Like, I understand that. And at the same time, like, is there a part of you, and I love your approach. You treat every patient as an N of one. Love that. But is there also a point where you're just like, stop being a pussy, commit to this, you know, and like, you can do it. I mean, I'm relatively recent in the last 2.5 years for you.
Yeah.
So there was 9 years before me, right? So how do you go about encouraging, letting that coach come out with your patients in terms of, like, look, I don't want to do your revision, and you can get a lot more out of this thing if you commit and you try?
Yeah, that's a good question. I think motivation, for people that you don't specifically know well, or that I may have only met once or twice, is hard. And so I think it's the connecting again. I think you have to listen to what they say, and then you can't. I've come to learn that you can never tell someone that they're not in that much pain,
dude.
I think when someone says something to you, that is their reality. And it's hard, because even though I know 90% of my patients aren't experiencing what you're experiencing, I still have to listen to them and say, hey, I'm so sorry you're feeling that. That's so, I think you have to connect, you have to show empathy, and then you have to encourage. And it's hard. And yes, do I have some patients from time to time that may have fibromyalgia, or, are naturally, or more likely to have low pain tolerances or struggle? Yes, I do. Cultures, some cultures are the same way, and it's just people anticipate pain differently, and they express pain differently, and it's hard. And but I think it's, for me, that's why I always make them follow up with my PA first.
Yeah.
No, I'm just joking. I'm just joking.
I didn't hire you for your expertise. I hired you to take the bullets. It's cool.
Take the bullet. I'll see you at the 6-week mark. No. In all honesty, I think the biggest thing before anything is setting expectations and meeting expectations. I love shooting videos. I love telling people, hey, go to my website, go to my Facebook page, go watch all the videos. I got like 180 videos on there. People walking, like, know where you should be and how people are doing. And in their mind, they're going to be thinking, I should be. I know comparison can sometimes be the great destroyer of joy, but at the same time, you can set an expectation in your mind that you should do well. It's funny how many people have their first knee and their second knee is just that much easier to go through because they've been there.
Yeah.
And until you can connect or help people to understand, hey, people have been here. They're where you're at. And guess what? You're going to go up. It's going to get better.
Well, so, I hope, with the footage that you and I have archived together, that it's less an expectation and more so proof of possibility. Like this is not where you want to take everybody.
Yeah.
And at the same time, don't sell yourself short.
Yeah, I love that.
Dude, I'll be completely honest with you, man. When I came out, the nerve block was still going, and my nurse comes in. He's like, "Hey, man, we got to get you up and walking." And I was like, really quick, before I get up out this bed, like I am going to be able to feel my dick again, right? Because I can't feel it.
You
Like,
had a full spinal, going on.
Dude, from the belly button down, nothing. He's like, sir, I can assure you everything went fine. You'll get all the feeling back, blah, blah, blah. And I was like, all right, man, like, give me the walker. Let's make it happen. Never, I don't care what happened to my knee. Do all the other, does everything else work? Okay, awesome. Priorities. Why knees?
Why knees?
Yeah.
I think, knees and hips. My fellowship was in knees and hips. And so replacements. And for me, I love working with my hands. I loved power tools. Like when I got into it, I thought it'd be great to do sports and go back and cover BYU as their doctor and be the sports guy. And I thought that was always my dream. And as I got into doing sports stuff with cameras and arthroscopy, it was cool. But I really like the hammers, the mallets, the saws, the power tools. And I just naturally.
Dude, that was my last vision before I went out, was seeing that Braveheart William Wallace torture table. And I was like, oh.
I haven't heard anyone describe it like that.
Oh, yeah, I was like,
so much stuff on there. Yeah.
What's about to happen right now? There's a hammer.
You don't want to know. You don't want to know. Why do you think I'm never going to have my knee replaced?
Oh, dude, I was just like, what's he about to do to me?
No.
Holy shit!
No,
that's wild, man.
Yeah, it is wild. It is wild. But knees and hips, I loved restoring function, and I loved anatomy, and people have a great appreciation when you can help them to do the simple things like walk again or get off the toilet, and you can take their pain away, and you give them back their life, and you give them the ability to go play with their grandkids or their kids, to take a walk with your kids, to go to the park, when I find people who come in and, and this is one question for anyone who's listening, people always ask, well, when should I get it done? And I tell them, when you stop doing the things you love within reason, when you start planning your day around your knee, when you, you can't even walk the grocery store. Yeah. Or when you start to lose range of motion. And when a lot of people start to hit 2 or 3 of those things, their life has changed. Yeah. And a knee replacement should help that. And
I know for me, I was experiencing a lot of challenges going from stop to start with my kids. And that was, and I'll put this feather in your cap, man. Like I mean this with all sincerity. I'm a better dad because of what you've done for me. So dude, I appreciate you, man. I'm glad you're out there in the world, and I'm glad you're, serving the veteran community in the capacity that you do, because dude, it was getting bleak there for a second,
Yeah,
and
thank you.
Yeah, there aren't a whole, it's a very short list, and but you're on it, man. You changed my life.
Oh, Michael, thank you. I appreciate that. That's kind of you to say. Yeah, I think a lot of people stop going to family events and stop doing things once their knees and hips get really bad. They limit their mobility, and they miss out on a lot. So yeah, we can definitely at least get you back to that.
Yeah. That's so important, man. I admire you, because you're not only amazing at what you do professionally, but you're as rock solid as they come as a father and a husband, man. I'm glad that you're in my circle.
Oh, well, thank you. I appreciate you too.
Yeah, dude. So for everybody out there that is like on the fence or starting to check those boxes of functional limitation, how can they find you, get a hold of you? Because Lord knows I refer you to at least one person a month.
Oh, I appreciate it. Yeah, so I have a couple different ways. My office right now is in Mesa. I operated a couple of places up in Scottsdale. There'll be a place in Chandler coming up, but I work for Arizona Sports Medicine Center, ASMC now. It's on Stapley and the 60, 1840 South Stapley and the 60. You can go to my website. It also has the information there. It's going across the screen. I see it's drmichaelsumko.com. And I also have a Facebook page, which is Dr. Michael Sumko, hip and knee specialist. So, and my son's starting to do my social media. So look for me on TikTok or Instagram or,
Let's go.
whatever he's gonna, start doing. I don't know how to do that stuff, but yeah, I think there's lots of videos. There's, abilities to find me on the internet. And then you can make on my website, that drmichaelsumko.com, you can actually make appointments to our office. It's linked to our office to online schedule. So you could do that too.
Cool.
Yeah. Cool. Thank you, Michael.
100%, man. For everybody out there on a mission to be the fittest leader possible, remember, it comes down to integrity, courage, and ownership. And if you're interested to see how you show up as a leader, take the leadership quiz at nextlevelhq.co. But it comes down to alignment first and progress always. See you next time.
It. Thanks.